Computer-aided diagnosis for optical diagnosis of diminutive colorectal polyps, including sessile serrated lesions, a real-time comparison with screening endoscopists. Introduction. Endoscopic characterization of diminutive, i.e. 1 to 5 millimeter polyp histology during real-time colonoscopy, so-called optical diagnosis, remains the most attractive intervention for an immediate cost saving in screening colonoscopy. With accurate optical diagnosis, diminutive lesions can be resected and discarded without pathological assessment or left in place without resection in cases of diminutive non-neoplastic polyps located in the distal colon. Unfortunately, this approach has not yet become a reality. Endoscopists fear the clinical and legal consequences of an incorrect optical diagnosis. In addition, despite the availability of optical diagnosis classification methods, the performance of optical diagnosis by endoscopists varies greatly, and not all endoscopists are able to meet the competence thresholds for adoption of optical diagnosis in clinical practice, i.e., the simple optical diagnosis accuracy standards set by the European Society of Gastrointestinal Endoscopy and the preservation and incorporation of valuable endoscopic innovation standards set by the American Society for Gastrointestinal Endoscopy. With the recent improvements in machine learning techniques, computer-aided diagnosis, CADx systems, have been developed to improve the accuracy and reliability of endoscopists' optical diagnosis. These advances have already led to the introduction of the first commercially available, regulatory-approved CADx systems. Although several of these CADx systems were able to reach the previously mentioned thresholds within prospective validation settings, none of the systems have yet been able to reach all performance thresholds. In addition, there remain several limitations that might hamper widespread implementation of these systems in clinical practice. First, the generalizability and reliability of the results of prospective clinical trials are still limited. This is related to the fact that most systems are tested in single-center studies and/or are not tested in a real-time endoscopy setting or compared with the performance of a representative group of endoscopists. Additionally, a CADx system should not omit relevant sessile serrated lesions, SSLs, as neoplastic lesions or use an endoscopy system that is not widely available. A study addressing all these issues would demonstrate realistic diagnostic performance of a CADx system when implemented in daily practice, which is an essential step before its widespread adoption in routine practice. In the POLAR study, the authors aimed to address all these issues by developing a CADx system, called POLAR system, that is able to characterize diminutive colorectal polyps, including SSLs, during real-time colonoscopy. The primary aim of the study was to compare the accuracy in optical diagnosis of diminutive colorectal polyps between the POLAR systems and a group of endoscopists during real-time colonoscopy. A secondary aim was to construct a publicly accessible colonoscopic imaging database that can be used to train, validate, or benchmark other CADx systems. Methods. The authors developed the polyp artificial recognition, POLAR, system, which was capable of performing real-time characterization of diminutive colorectal polyps. For pre-training, the Microsoft COCO dataset with over 300,000 non-polyp object images was used. For training, 8 hospitals prospectively collected 2,637 annotated images from 1,339 polyps. For clinical validation, POLAR was tested during colonoscopy in patients with a positive fecal immunochemical test, FIT, and compared with the performance of 20 endoscopists from 8 hospitals. Endoscopists were blinded to the POLAR output. Primary outcome was the comparison of accuracy of the optical diagnosis of diminutive colorectal polyps between POLAR and endoscopists. Histopathology served as the reference standard. Results. During clinical validation, 423 diminutive polyps detected in 194 FIT-positive individuals, that is 300 adenomas, 41 SSLs, and 82 hyperplastic polyps, were included for analysis. Polar distinguished neoplastic from non-neoplastic lesions with 79% accuracy, 89% sensitivity, and 38% specificity. The endoscopists achieved 83% accuracy, 92% sensitivity, and 44% specificity. The optical diagnosis accuracy between polar and endoscopists was not significantly different. The proportion of polyps in which polar was able to provide an optical diagnosis was 98%. Conclusions. We developed a CADx system that differentiated neoplastic from non-neoplastic diminutive polyps during endoscopy with an accuracy comparable to that of screening endoscopists and near-perfect success rate.